Hi, I'm Jenna Priest, and I'm going to be presenting on the effects of direction and incline on treadmill walking in typically developing children. Treadmill walking is a common rehabilitation technique used for children with disabilities. Clinicians will frequently modulate treadmill walking conditions such as direction and grade to achieve better training outcomes. Now, both backward and incline walking have distinctive gait patterns in adults. However, there's minimal literature describing how children adapt to these conditions. It's important, therefore, to understand how children adapt to these before introducing them as a part of a treadmill protocol for children with disabilities. So to do this, we recruited 19 typically developing children aged 5 to 12 years. Subjects completed one bout of 2 minutes of treadmill walking for each condition. Treadmill walking conditions included forward and backward walking at each of 3 inclines, 0, 5, and 10%. Spatiotemporal and joint kinematic data were collected using an 8-camera Vicon motion capture system, and 2-way ANOVAs with repeated measures were used on all variables. So here are some of our results. These graphs show the mean step length and width of forward walking in blue and backward walking in orange at each of the 3 grades. There was a significant direction effect for both step length and width. Backward walking at all grades resulted in a significantly shorter step length and a significantly greater step width. These findings are in line with how typical adults adapt to backward walking. There were no significant changes in step length or width with regard to incline. Now, this is in contrast to findings in adults who tend to shorten their step lengths at greater inclines. These graphs show the mean dynamic range of motion at the hip, knee, and ankle. This dynamic range is representative of the degrees of the arc of motion the joint moves through. There was a significant direction effect for peak hip flexion and extension, knee flexion, and ankle plantar flexion and dorsiflexion. Similar to what's seen in adults, there was a decrease in the range of motion about the hip, knee, and ankle during backward walking. We found no significant incline effects for lower extremity joint range of motion. However, adults tend to adapt to incline walking by decreasing knee range of motion. We did see a slight non-significant trend in this direction during forward walking, but not during backward walking. Adults also tend to adapt to increasing grades of incline by increasing peak hip, knee, and ankle flexion, and we did not see this in our typically developing pre-adolescent subjects. Finally, we found a significant incline by direction interaction for foot clearance and mid-swing. We saw that greater levels of incline resulted in an increased foot clearance in both directions. However, foot clearance was greater during backward walking on a level surface, but greater during forward walking on an incline. To our knowledge, there's not adult data that discusses the effect of incline on foot clearance and mid-swing, so we can't draw any conclusions about whether the patterns we saw represent mature or immature adaptations. In conclusion, our results suggest that typically developing children adapt to backward walking similarly to adults, taking shorter and wider steps and limiting range of motion about the joints of their lower extremities. However, while adults adapt to increased inclines by decreasing knee range of motion and step length and increasing peak hip, knee, and ankle flexion angles, these changes were not yet seen in our typically developing subjects. This may suggest that typically developing children's ability to adapt effectively to incline walking remains immature in pre-adolescence. Alternately, the presumed novelty of the task may have been a factor. Thank you for listening, and if you have any questions, please feel free to contact our team using the information on this slide.